And get started here. So, as I was joking, I like to claim that I got dressed up for Jaimie. We'll just go with that reason. We'll say it's true. So it's a sincere pleasure to introduce Professor JaimieHenderson, who is the wonderful functional neurosurgeon here who puts in nearly all of the deep brain stimulators to control Parkinsonian tremor that we talked about briefly in the first couple of lectures in class. So without too much further ado, I'll turn it over. I want to make one last connection though before he describes a lot of the work that he pioneered in deep brain stimulators. Previous to that was really trying to do so-called frameless stereotaxy, so you know where the brain is, where the skull is, without actually having to clamp onto the brain or the skull in quite the same way. And sort of the third area that he's pioneering, it's a great pleasure to do that with him as partner in crime, on the human translation of prostheses. So you've seen several videos of our wonderful participant here in the Stanford area who's controlling cursors, and of course we spent the last month or so going through all the detailed mathematics of how to do that. Jaimie is not only a close collaborator in that, but is also the PI, the principal investigator in charge of all that on the clinical side throughout the entire program. So, Jaimie?
Okay, thanks, Krishna. Unfortunately, we're cutting off quite a bit of the bottom of the slides here. I don't know if that's something that we can adjust, or I guess we should have tested that first.
Didn't notice that.
The reason being that it's going to end up.
The resolution is probably the.
Yeah, I don't want to spend too much time on it, but maybe we can do something to correct it. I hope I don't have to mirror, but maybe that's what it will require.
I'm guessing this is 11 something by.
Yeah. Well.
Probably not as.
All right. Maybe just have to. Sorry, guys. And how do I?
I don't know why it's giving you the resolution.
Yeah. All right. Well, I'll just go ahead and we'll just go ahead and get started. And unfortunately, some of the references and such will probably be cut off at the bottom, and you may not be able to. So hopefully this. Hopefully it won't have too much effect, but we're missing a fair amount of the slides here. So anyways, thanks, Krishna. Thanks for the opportunity to talk. Nice to meet everybody. Thanks for having me. Hopefully this will be something interesting, not too boring, not too far off of what you guys are already working on. I'm going to talk about, as Krishna said, deep brain stimulation, which is placement of electrodes into the brain to treat various different neurological disorders. I'm going to talk a little bit about indications. I'm going to talk a moderate amount about technique. It's something I'm, as a surgeon, particularly interested in. And then I'll show some of the results. And so just kind of a basic overview of what the procedure looks like, what we can treat with it, and how people do afterwards. So what are the indications for deep brain stimulation? Well, probably the most common one is Parkinson's disease. And by the way, these patients have all given their permission to be videotaped and to have their images appear. So the ones that are de-identified have given their permission. This is a typical Parkinson's patient. You can see that he has this very recognizable sort of resting tremor, this paucity of spontaneous movement. You can see how difficult it is for him to do even a simple finger opening and closing task. This is called bradykinesia, which is which is Greek for slowness of movement. The resting tremor is maybe the most recognizable part of Parkinson's disease, but they also have rigidity, a stooped posture, and often gait disturbance as well. So this can be a very debilitating disease, as I'm sure most of you are aware. How do we decide who gets deep brain stimulation? Well, patients have to have idiopathic Parkinson's disease, which means that they have a disorder that is not something that looks like Parkinson's disease, but actually is diagnosed as Parkinson's. And there are a whole spectrum of movement disorders that can look like Parkinson's. They have to have a good response to medication. So these are people who have taken medicine, Sinemet being the most common one. This is different from what I used to. And very wide fluctuations. So when they take their medicine, they're doing pretty well, except they may have these abnormal involuntary movements. Anybody ever seen Michael J. Fox speak on TV? Ever sort of notice how he's dancing around like this? That's dyskinesia. That's a side effect of the medication. It's really important for these people to have a supportive family environment because stimulators are somewhat complicated. They may be difficult to adjust, and you want to be sure that these people come back to come back into the office to have these things adjusted over time. And of course, it's important that they have no significant medical risk factors. So what are the other indications? Well, there's something that many people can maybe mistake for Parkinson's. It's called essential tremor. And I'll just run this video again. You can see this gentleman has this tremor with action, extremely severe, but when he stops moving, and the video cuts off here, but when he stops moving, the tremor goes completely away. So it's different from Parkinson's, and instead of it being during rest, it's during action. These are probably hereditary disorders. It often runs in families. It's usually slowly progressive, and it's mainly the limbs, but it can sometimes also involve the head as well as the trunk, and sometimes can involve walking. And it's interesting that deep brain stimulation is primarily effective for this distal appendicular component in the limbs. Dystonia is another indication for deep brain stimulation, and this is a kind of heterogeneous disease that involves either slow twisting movements or contractions of the muscles throughout the body in an uncoordinated way. There are a number of different kinds of dystonia, but the ones that we're most interested in treating are particularly the childhood hereditary dystonias, which are, it's called a DYT1 gene positive. And so these are kids who, by their teenage years, are often dead because they have very severe, as you can see here, is a photo of a kid with these very severe deforming muscle contractions. And they, because of this, because they're in constant motion and their muscles are constantly working, it's hard for them to even take in enough nutrition to keep themselves alive. And I'll show you some videos at the end of some kids who have had deep brain stimulation done. And this can really be life-changing for these kids. There are a number of emerging indications for deep brain stimulation. I'm only going to show you this slide. I'm not going to really talk about these today, but it's interesting that because we've had such success with deep brain stimulation in movement disorders, it's possible that we can also try to consider applying this to other conditions. These are things like Tourette syndrome, which you guys are probably familiar with. It involves tics and vocalizations, which are often profane. Cluster headaches, which is a very specific type of syndrome with a headache behind one eye. Obsessive compulsive disorder, major depression. There have been actually a couple of trials on major depression, unfortunately not showing promising results, but this may be just because we don't quite understand the disorders well yet. And epilepsy. This is deep brain stimulation for epilepsy is going through the FDA and may soon have approval. We believe it probably will. And there's a whole host of others that are in development. I'm personally interested in using deep brain stimulation for treating the cognitive and attentional deficits that are associated with traumatic brain injury. And just yesterday, I got notification from the FDA that my IDE was approved. So we'll be starting probably in the fall to implant some patients in that trial. So that was a major milestone. Okay, so how do we do deep brain stimulation? So this is, again, a typical Parkinson's patient. You can see he's got this kind of stooped posture. His face doesn't move very well. He has this paucity of spontaneous overall movement. But if we took a look at his brain, the surface of the brain and the structures inside wouldn't really look grossly different from anybody with a normal brain. The area that we're interested in is actually physiologically different. And the reason it's physiologically different is because of a lack of dopamine in an area called the substantia nigra. So the lack of dopamine in the substantia nigra leads to abnormal oscillatory activity in the brain, and particularly in this area called the subthalamic nucleus, which is a approximately 6 by 7 by 8 millimeter structure. So this is about the size and shape of a large lima bean that sits underneath the thalamus. So here you can see the STN in place. So our task, my task as a surgeon, is to target this structure, this very small structure, very deep, really essentially right in the middle of the brain, and introduce an electrode 1.27 millimeters in diameter, and this is an example of that electrode, into that target blindly and figuring out a way to do that. So how do we do this? Well, you guys are probably familiar. I don't know, Christian, if you guys have talked a little bit about stereotactic technique. So in order to do many of the types of recordings that you guys have been talking about in class, originally, many of these were done from deep nuclei of the brain. And in order to do this, one has to have a system for placing an electrode precisely in a part of the brain. And this was a technique that was developed around the turn of the 19th century by Horsley and Clark. And it was originally used to study the cerebellar nuclei in monkeys. And the essential idea here is to superimpose an XYZ coordinate system on the brain. So for every slice of the brain, you can specify an X and a Y coordinate in whatever arbitrary units you'd like. We usually use millimeters. And then depending on the slice that you're on, you can define the Z coordinate so that you can then specifically say, if I'm going to go to, for example, -11, -3, -5, you know exactly where that is with reference to a particular spot in the brain. And there are lots of different ways that one can reference this. OK, so how do we do this? Someone's messed around with my... All right. So traditionally, we do this using something called a stereotactic head frame. And that's this device here. It's sort of this medieval torture device that attaches by pins to the skull. And you can use these coordinates adjusters here. There are little clamps on this that you can move the anterior posterior. You can move it up and down, and you can move it left and right. So this allows you to precisely position your end effector in that three-dimensional coordinate system. Now, this was originally developed before volumetric imaging, before CT or MRI scans. And it relied on the fact that one monkey brain looked pretty much like another monkey brain. The problem is, of course, human brains are different because everybody's skull is different, everybody's brain is different. So we have to have some way to volumetrically image these things. So modern stereotaxis uses CT or MRI. Here's a patient enjoying a head frame application. This is incredibly uncomfortable, very claustrophobic. And during my training, I observed many of these things being placed and said, I'd really like to do something different or better. And when we do these operations, we actually operate on people awake. And so here is a man undergoing deep brain stimulation. You can see he's sort of trapped in this metal cage, and it's not a very pleasant experience for people. So I spent a fair number of time, Krishna mentioned this earlier, developing a system for doing this framelessly. So using computer techniques and image guidance and image-guided tracking to eliminate the stereotactic frame so that we can now perform surgery with people in much more comfortable positions. So this gentleman, no frame, he's lying comfortably with his head supported but unrestrained, and he can move, adjust his position, and it's much more comfortable for patients. We have done quite a bit of research on this just to make sure that it's going to work the same, and it turns out that it does. So it's as accurate as a stereotactic frame. In fact, I believe in some cases more accurate, and the clinical motor outcomes are identical or even better. So in all ways that one can evaluate these things, it turns out that it's every bit as good. OK, so how do we do this? Well, unfortunately, we still have to put something into the person's skull. Why do we have to do this? Well, modern imaging techniques, accurate as they are, still have a difficult time registering or aligning those two data sets. And I'll show you what this means in just a second. The data set of the person in the operating room, and we want to make sure that we correlate the person's location in the operating room precisely with the location in the computer. So making those two coordinate systems congruent is one of the fundamental tasks of image-guided surgery or of computer navigation for surgery. So in order to do this, we place these small, these little small markers. They go about 4 millimeters into the skull, and then they have a little ball on top that is imaged quite well in CT or MRI. This patient she has an interesting story. This is my very first frameless case. I did this at the Cleveland Clinic in probably 2001, maybe 2002. She had been waiting years. She waited over 2 years to have this operation done. And the reason she couldn't have this done with the stereotactic frame is have a look at how her neck is. That's a fixed deformity. She can't straighten her neck out. So in order to even get her in the MRI scanner, we had to prop her butt up with pillows in order to sort of get her head into the scanner. And if we tried to put a frame on, she wouldn't fit. So she waited until we developed this technique and said, OK, I trust you. Go ahead and do it. So the pressure was on that very first time I did this because she expected this to be just as good as the standard technique. So then once we've imaged the person using a CT scan, so this shows a CT scan image, and I'll show you, you saw in the next slide, the real picture of this person's head. These are the fiducial markers that we've circled here. And then this is the way that these look on a coronal, sagittal, and axial section. So these are the 3 different planes that we slice through the brain. The scans are acquired in the axial section and then reconstructed. And we select the very center of this. It looks kind of like a Pac-Man. It's round with a little divot out of it. And we store the location of each of those markers in the computer. So now we know precisely, with a high degree of accuracy, the in-plane resolution here is about 0.3 millimeters, and the out-of-plane is anywhere from 0.6 to 1 millimeter. So it's a very precise location in 3-dimensional space. We then, so this is the patient's head. You can see there are these little bumpers that we have used in the past to protect any bumps to make sure these things don't get dislodged. But our task now is to say, OK, now that we've decided where we are in the computer space, we need to show the computer where we are in physical space. And the way we do this is by using a system that tracks these reflective spheres through 3-dimensional space using 2 cameras that are aligned binocularly, similarly to what our eyes are. They're 2-dimensional CCDs that triangulate the position of each of these reflective spheres in 3D space to an accuracy of about 0.2 millimeters. Once we know where these spheres are, and we know the geometry of the instrument, we can extrapolate the tip of that probe again to about a 0.2 millimeter accuracy. This is a reference that attaches to the patient's head, in this case just with a little elastic strap, in order to make sure that we know where the head is with relationship to the instrument. And then when we know all those pieces of information, where is the head with relationship to the camera, where is the instrument with relationship to the camera, and where are the markers with relationship to each other in order to display those on the computer, then we can register those 2 spaces together. So this is the mathematical fundamental of frameless surgery. And this is what allows us to get rid of the stereotactic frame. Once we do that, then we can plan the operation on the computer fully. So we can select an entry point, we can select a target point, we can do all sorts of 3-dimensional manipulations with the data offline and inside a computer system. We can recreate those in the operating room by simply registering those 2 spaces together. So it allows us to very powerfully have sort of an X-ray vision approach to surgery. OK, so sorry, for those who may be squeamish, there will be some surgical images, but I promise not a lot of blood. Yes?
If you're still doing these by hand, how do you compensate for any potential movement?
Right. So bear with me. Bear with me. So there's our entry point. So then there's a burr hole that's made, an incision is made in the skin. We put something on called a stim lock. It holds the electrode in place. We then attach this high-impact plastic tower to the skull with screws. These things are very rigidly attached. When we tested these in cadavers, we did our very best to try to dislodge them because we wanted to make sure, and again, this goes to your question about movement. We want to make sure everything is absolutely rigid, that there's no movement with relationship to the reference frame. So I mean, I even tried putting my head on, or my foot, to tear this thing out and it wouldn't come out. So definitely these things are firmly lodged. So this is the step that is important. So now, because we've got this base that's going to form the premise of our entire guidance system, we can attach a reference. So this reference now, however the patient's head moves in space, this reference will move with it. So it makes this entire construct, these fiducial markers with relationship, and fiducial is just a word it's actually from surveying. It just means reference. So fiducial markers, these reference markers, with relationship to this, bear a fixed relationship, and so it's the instrument that moves. And again, these are tracked in the operating room. So I'm pointing back to those, and it's quite accurate. If you point back, so here I am pointing back to one of these markers in the operating room. Again, as I said, the in-plane resolution here is about 0.3 millimeters, and out-of-plane is about 1. So we're within less than a millimeter of our target point. And that's the kind of accuracy that you need in order to introduce that electrode 8 centimeters deep into the brain to a less than 1 centimeter target. Okay, so once we've done that, then there's a guidance platform that goes on the top. There are these 2 screws, and this is a polar alignment system. I don't know if we have any astronomers in the room. Anybody know what a Dobsonian telescope is? It has 2 axes, a rotation and a sweep, and this thing works in exactly the same way. So during the alignment phase, this is me with an alignment tool, and I'm looking at the computer screen playing a little game here, where the object is to take this aiming reticle and the aim point and move it until this aim point is directly in the middle of the target. Now this is an interesting task because there's some noise in the system. There's thermal noise, there's micro movement. So this thing is sort of bouncing around like this. So it's important to try to, as best as possible, get that thing right in the center. And I've asked the manufacturer to have it make a zapping noise, but they haven't come through for me on that. So I'd have to do it myself. People look at me a little strangely. Krishna can attest to this. Okay, the alignment process involves, it's a 2-phase thing where you sort of sweep this through to try to get it through the target, and then if it doesn't go through the target, you then rotate it and sweep it through until you finally get the thing aligned with the target. Once that's done, then we attach this lightweight plastic microdrive, which you might not believe it, but is extremely accurate precision instrument. It allows us, through 15 millimeters of travel, a 50 micron error. So we are accurate to within 50 microns over that 15 millimeters of travel. We usually start recording. So here's the electrode. This is a microelectrode that you guys are familiar with. Sorry about all this being cut off, but there's nothing much we can do. This is the active electrode. This is the ground. This is an active shielded cable. It goes off to a recording setup that I'll show you in just a second. And then this handle allows me to advance this in very precise increments. We can dial in individual neurons and listen to those cells as we advance. So how do we do this? Well, there are a number of different targets for deep brain stimulation. So let me tell you a little bit about a target called the, cut off here, the ventral intermediate nucleus and the ventral oralis nucleus pars posterior. These are all lumped together in the Jones Atlas as just VL, but in this neurosurgical atlas, they're a little bit more parcellated, and this has to do with the fact that they receive different inputs from different parts of the brain. Regardless of that, we'd like to try to sort of be in this area here. So this is the entirety of the thalamus here. This is the internal capsule. Here's the subthalamic nucleus, the red structure that I showed you guys before. This is the yellow thalamus that you saw before as well. So we're aiming at a particular point, and this is in reference to an internal reference system in the brain called the anterior commissure posterior commissure point, or ACPC plane. And so at the midpoint of that plane is the reference system that we use as 0, 0, 0. So we're going for a very specific point. So this is all well and good, and I showed you the system that can allow us to get there with a pretty high degree of accuracy. But how do we know that we're really where we want to be? How do we know that we're going to be able to put that electrode in exactly the spot that we want? Because if you see this is 1.27 millimeters in diameter, if we're a millimeter off, that makes a difference. This is the sensory thalamus back here. If we're up here, it's not going to do any good at all. So we have to be in this very narrow window for this to actually work the way we want it to work. So how do we do this? Well, that's where micro recording comes into play. Even though we've gotten what we think is a pretty accurate initial pass at what we're going to be doing, we still need to confirm that this is going to be physiologically what we want. So our first pass is we purposely go a little bit posterior. So we're in a part of the thalamus called VC, or also called VPL, depending on the nomenclature. We're looking for tactile responses. And what you're going to see in the next video is my colleague, Dr. Helen Bronte-Stewart, who is a neurologist who helps me in the operating room. She's going to be brushing the patient's hand with a paintbrush. And you'll be able to hear the neuronal responses. So those neurons are going to be responding to a particular sensory receptive fields. Each neuron in the thalamus has its own unique receptive field. Some of them overlapping, some of them bigger, some of them smaller. This particular receptive field is just of the palmar surface of the thumb. And you'll see Dr. Bronte-Stewart brushing other parts of the hand and then coming back to that palmar surface of the thumb. So you can see as she's brushing here that that's a very, very easy to hear response. So this tells us we're getting into the right spot. You can see patient's awake, patient's cooperative, helping us during the operation. This is the recording system that we use. It's actually pretty old school. This thing is ancient and needs replaced, but it still works great. It's preamplifiers, amplifiers, signal conditioners. There's a 60-cycle filter that we put on it, and then a computer display that shows us what the spikes look like on the screen. So this is all. We have all this with us in the operating room, and you can see Helen's wearing her headphones. We have actually a multi-channel, really nice, actually professional-grade wireless system. So anybody who comes to the operating room gets a set of headphones, and you can listen to this yourself. Okay. Happen as you get more anterior, and we get more related to movement than to pure sensation, and it's sort of a gradient as you go through the thalamus, as well as deep muscle spindle responses. And then finally, on our third pass, we're maybe just a little anterior to the target, but this is pretty close to the target track, and this is what we call the VIM-VOP junction. This is where there's lots and lots of tremor cells, and when we stimulate in this area, we can suppress the tremor. So here you can, on the next slide, you'll hear those tremor synchronous cells. There you can see the tremor, and you can hear the synchronization of those tremor cells. And this tells us that we're in a good location. So we then introduce our electrode after doing some test stimulation to make sure that we're actually in the right location. Okay. Someone has clearly sabotaged my slides. Jonathan? All right, so then the next phase of the operation is placement of the pulse generator. So this is usually done a week or so later. We stage it because oftentimes we always do this under general anesthesia because we have to tunnel underneath the skin in order to place the pulse generators. And it's pretty uncomfortable for patients. And if you put somebody, particularly a Parkinson's patient who may have some cognitive trouble, if you put them through a long, stressful, difficult surgery, and then you immediately put them under general anesthesia, sometimes they don't wake up for a couple of days. So it's, I think, much better to stage that pulse generator and give them a little chance to recover in between. Okay, so it's usually placed a week or two after the lead implant, and we usually activate it a bit further out than that, and the reason being is that this allows for some resolution of inflammation and tissue reactions. So there's it's actually a very well-described phenomenon. When you introduce something into the brain, there's an inflammatory response that can vary in intensity. And by about 4 weeks, this has all died down. I used to try to program these patients immediately after we implanted the electrodes. The problem with that is you can get good response, but then the milieu of the brain begins to change, and over time, that programming just sort of fades off, and you have to bring them back in and reprogram them, and it fades off, and you bring them in and have to reprogram them. So it's this sort of cycle. If we wait, we can usually program them, and things work pretty well right off the bat. The stimulators are programmed, and this is what the pulse generator looks like. So here's the actual pacemaker device itself, and then this is the lead, just to give you a sense of the scale. These are programmed using a wand that communicates wirelessly through the skin. So it's, again, pretty old technology. Most of the stuff here is sort of 1980s, 1990s technology. And you might ask, well, you've got all this really cool Bluetooth, new stuff, microprocessors, et cetera. It's about the FDA. It's about safety. I want to make sure that these things are tried and true and tested, and something bad is not going to happen to people. So that's why much of the medical technology lags a little bit behind what you could go to Fry's and buy off the shelf. And again, this is programmed. We can program any combination of these contacts to be positive or negative. We can program pulse widths from microseconds, from 60 microseconds all the way up to 450 microseconds. We can put in rates from 2 hertz all the way up to 185 hertz. So there's lots of different ways that we can program this and adjust it in order to get control of the individual patient's symptoms. Okay, so how does it work? Yeah?
Are the optimal stimulation parameters pretty different from patient to patient? And how do you do this?
That's a good question because it's actually a multi-layer question. The first is the question, is there an optimal set of programming parameters in a canonical perfect patient and perfect placement? even that is unknown because the parameter space is enormous and not a lot of systematic work has been done. In fact, in recent years, people have been exploring regimes different than the ones we usually use with very interesting results. So again, because this is a medical treatment, when you find something that works, you generally stick with it. Again, just pragmatic medicine. You know, this is working, don't mess with it. Once you've begin to run into some problems, though, that's when you start to mess around. When you sort of reach the limits of the technology, we're at that stage now where people are starting to look at different programming parameters. So does that answer your question? But generally it's somewhere between the 130 to 185 hertz, usually 90 microseconds pulse width, usually contact 1 if the lead is placed correctly, because that's the one that's sort of in the sweet spot of the target structure as we've sort of found out over many years of doing this. Yeah?
If like those parameters that you just mentioned don't work, how do you decide which way to change the parameters? That's
the art of programming. So, you know, a lot of it depends on how the. So we start off every programming session with what's called a monopolar review. So we take each contact, make it a monopolar cathode, and then ramp up the voltage using a particular frequency, the frequency that's been known to be effective. So it's usually 130 hertz because we know that that's an effective stimulation. Now 90 microseconds and 130 hertz should work almost always. And then we just ramp those up and we look for side effects and for therapeutic response. And then once we found those through that, and it's a lengthy process, takes hours to do. But once we found all those thresholds, then we know where we are and we can begin to do the sort of in-depth programming. So it's a huge parameter space to explore. Yeah?
What's the maximum voltage level that you can go up to?
The pulse generator goes up to 10.5. It'll begin to give you warnings at about 4 volts that you may be causing tissue damage because of the, depending on the settings. We usually use right around 3 volts. So 3 volts into about 1,000 ohms. So it's about a 3 milliamp current that goes into. But again, it changes depending on the voltage, depending on the impedance of the electrodes. Okay. Oh, all right. Yeah.
How was this particular region of the brain found out to be affected?
So that's an entire other lecture, which is a little bit about the trial and error of functional neurosurgery. So there's a little animal research and a lot of human experimentation. So that's kind of what the history looks like, and I find it fascinating, and I have an hour's talk on the history of functional neurosurgery. But the short answer is mainly from lesions and from knowing human neurophysiology, but very much informed by animal studies.
Are there any situations where it is beneficial to inhibit neurons instead of exciting them?
That's making some assumptions that we're exciting these neurons, or that we're inhibiting these neurons. So that's another hour talk on mechanisms of deep brain stimulation, which is another big area has been an area of interest for me. So it's neurons react differently depending on where they are in an electrical field, how hard you're stimulating them, whether you're hyperpolarizing or depolarizing, positive versus negative, what the pulse width, what the pulse sequence looks like. All of these things make neurons respond differently. So to say that we're either exciting or inhibiting is a little, it's way, 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 way more complicated than that. So hopefully that answers your question. Okay. All right, so this is kind of the fun part of the talk, so I want to make sure we have enough time for it. Here's the results. So here's our patient that we recognized from before. And when we do this in that target that I showed you before in the thalamus, we can often get pretty close to complete relief of tremor. So here he is after surgery with the stimulator activated. And as you can see before, going to a restaurant was a disaster for this guy. He wouldn't do it. In fact, he was starting to have trouble dressing himself because he just couldn't do buttons or zippers. His wife had to do everything for him. He was essentially an invalid. And so here he is after surgery. So many patients will achieve very significant reduction, and some of them will get pretty close to complete tremor relief. So this is, again, similar to some of the older lesion operations, but with fewer complications. So here's one of those kids with dystonia. His family has this gene, and in fact, his younger brothers are starting to show some of this. So you can see he's trying his best to walk. And he's a young kid, active. He doesn't want to be in a wheelchair. He doesn't want to use a walker. He just wants to walk. And so he's going to show us. He wants to show us. He's going to show us that he can walk. But eventually he just says, man, I just can't do this, and just gives up. So, these kids are, and this is not yet the late stage of the disease. This gets worse as they get older. And here he is about a month after deep brain stimulation. You can see the hair's growing back. The incisions are healing up pretty nicely. So, here he is after DBS. This is a different target. This is an area called the globus pallidus, which seems to be better for this sort of thing. And he's doing pretty well here, but things will get better even over the course of a year. And often at the end, at the end of a year or so, these kids are indistinguishable from their peers. So we've taken what's essentially a fatal disorder, or very close to it, and made these kids normal. So that's pretty gratifying to be able to do that. And then finally, I'll talk a little bit about Parkinson's outcomes, and I'll just kind of let this video play. And just go from there.
I was first diagnosed with Parkinson's in May of 1995. It just overtook me. Everything revolved around my Parkinson's, it seems.
In this home video, Art Davis documents what had become a daily struggle with Parkinson's disease. He is 57 years old, but the effects of the disease had reduced him to a state of near infancy. Some days he was barely able to move, or there were the moments when his body was plagued by uncontrollable, erratic movements. He never knew which to expect. Medication no longer helped much. The only certainty in Art's life was that the symptoms of the disease were getting worse.
Next to our ambulance.
It's 6 o'clock in the morning, and Art is facing hours of surgery. He is off medication and barely able to move.
I hope to be able to do things that I haven't been able to do. This disease has just consumed me over the last 8 months. The first few years, I was in control. But for the last year, it's been in control.
A couple of hours later, a team of surgeons are hoping to give Art some of that control back by working deep inside his brain. They begin by isolating the area in the brain responsible for the onset of Parkinson's. Art is awake for almost the entire procedure. The brain feels no pain. The surgeons have found the spot now where they need to be. They implant an electrode which will deliver a continuous electrical impulse to Art's brain and inexplicably ease his symptoms.
Let's go to 2 volts.
They experiment with a small amount of current in the operating room. Art is given some instructions to see if the stimulation has any impact.
Close and open. Close all the way and open. Fast as you can. Look up. Fantastic. Very good. Fantastic. Good. Tap your finger like this. Big and wide now. Big and wide. Could you do that before? When you're off? No.
The surgeons feel good about the way things are going so far, and so does Art. The nurses put his wife on the phone to hear the good news.
It's good results. We're having real good results. I'll be able to chase you around the yard.
Okay, good. That's great.
The team's spirits are high, but the outcome is still uncertain. Once the surgery is complete, Art will spend the night in the ICU to make sure there are no complications. A few more rounds of surgery will complete the implant. And we are back. With me here tonight is Dr. Jaimie Henderson, who we just saw at the other end of a piece of scientific equipment, and we are happy as well to say with us here tonight is Mr. Art Davis. got some complaints for chasing your wife around the yard. When you look at that piece of videotape, that's you, and yet it must feel like an out-of-body experience.
Yes.
What does it feel like now, knowing that was still you then, that you had absolutely no control over your musculature?
I feel 20 years younger. I've not had one bad moment since I've had the surgery.
Okay, so hopefully you guys will agree with me that DBS is now a well-established treatment for movement disorders. We can get very nice results in tremor, dystonia, Parkinson's. Unfortunately, we still haven't yet been able to get these kinds of results with some of the other neurological disorders that we're studying, but we hope to do so in the future. And I think continuing to improve the technology and thinking deeply about these problems, applying the sorts of knowledge that you're getting now in classes like Professor Shenoy's class, you guys are the next generation that's going to take this technology and improve it and really be able to cure, well, cure is a strong word, but at least palliate many of these neurological diseases. So I look forward to that day. And thanks, K-Dog.
I think we have time for questions.
Yeah.
About 5 minutes or so.
Retaliation's going to suck, I know. Yeah.
So the news was saying that he wasn't responding to medication, whereas that was, I would assume, a contraindication from what we saw earlier. Why was the choice made to?
Well, I think, again, this is a little bit of the media misinterpreting. If you let your eyes see what was going on with him, you noticed at one point he was sort of crawling on the ground. That's when his medicines weren't working. Then you saw him dancing with his pool cue. That's the opposite extreme. That's the dyskinesia that we talked about that Michael J. Fox has. So those wide fluctuations, and as Brian Williams said, you could never predict which it would be. They can be walking, someone can be out shopping or something, and all of a sudden they're frozen. They can't do anything. They're stuck. And imagine that. You're out in public and you're feeling fine, and you're all of a sudden frozen, stuck, and can't do anything. So that's the state that they get to.
Is this permanent?
Deep brain stimulation? So that's a great question. What it does is it reduces the symptoms to a particular point. Parkinson's, however, is a progressive disease. So as the disease continues to progress, that even though it's a differential over what their symptoms are, it gets less and less. And there are certain things it helps and certain things it doesn't. It can help. It does not help speech, for example, nor does it help cognitive functioning. And those are two big problems for people with Parkinson's. I've had patients who have been implanted 10 or 15 years, still able to move their limbs pretty well, but just not able to speak, not able to walk very well, because sometimes walking doesn't respond as well. So it helps, but it's not a cure.
When did it become approved for standard use in the clinic, or is it?
Yep, 2001 was when it was approved. The initial trials of DBS in this country started in 1990. Well, I was involved in the original trials in 96 and 97, so right around that time is when we started using it. So 2001 was the approval for tremor, 2004 for Parkinson's.
And when did it become kind of a standard practice?
Well, unfortunately, we're still getting to that point. We have to convince neurologists. It was interesting, I saw a patient in the clinic the other day who they can have bad side effects, so it's not 100% safe. It's brain surgery, and some of those can be potentially bad. And I think this is why there's some resistance sometimes still in the community. See, somebody who hasn't asked a question yet.
So what's kind of like the leading thought behind biology of how this works? Is it that kind of disrupts this neural firing, or it seemed like it was almost like this ordered seizure of the neurons, and you're just kind of gating and stopping.
It's one of the leading theories that there is a specific frequency band of oscillatory activity in the 13 to 35 hertz range called the beta frequency band that appears to be sort of anti-movement. And it appears that you need to reduce this beta band in order to enable movement to occur. And it appears that in Parkinson's, that beta band activity is elevated. So in work that I've been doing with my colleague Helen Bronte-Stewart, who you saw in the operating room helping me out, she's leading up a very interesting research study in which we use these pacemakers that are equipped with the ability to sense signals. So they can read signals out from the brain, store some on board, and then we can then telemeter them out to a computer. And we can look at how that beta frequency band changes when they're moving, when they're at rest, when they're standing, when they're sitting. So we're finding some very interesting things about how that beta band changes with various activities and what the different frequencies of stimulation, whether it be 130 hertz or 60 hertz, do to those beta band frequencies and how that correlates with symptoms. So we're right in the middle of that research project and should hopefully be able to tell you more later. But there are a whole host of lots and lots of different ideas about how this might work, all the way from a local suppressive effect to very complex network effects. And they probably all have something to do with it.
Do you always have that like ordered firing, or is that order kind of a simple?
Nope. I mean the tremor synchronous firing? Yeah, that's very specific to that region of the brain and that particular symptom. So in Parkinson's disease, some patients don't have a lot of tremor. And we don't see a lot of synchronous tremor activity when we're in the subthalamic nucleus. But what we do see is when we look at the spectrum of the neural signals, when recorded from large populations of neurons, we can see these patterns that emerge. And hopefully use them as biomarkers to help understand what's going on and also to help improve our treatments. Okay.
So the frames are used in other treatments like gamma knife radiation.
Right.
So can the frameless technique be used for that, or has it been applied to other techniques?
Good question. And in fact, invented here at Stanford is something called the cyber knife, which is gamma knife without a frame. So basically using, it's an industrial robot that mounts in a linear accelerator, moves it around. The head is tracked by two simultaneous X-ray machines. They're taking pictures at all times. And the robot can adjust itself if the patient moves a little bit. But you still have to have some way of sort of fastening them down. So yes, the answer is yes, you can.
So the brain is like a squishy material, right? So during implantation and after implantation, is it a very serious issue that the brain moves relative to the electrode, and because of that there are some side effects?
So the answer to your question is no. However, it is something we worry about because the brain can move, particularly when we open the skull, cerebrospinal fluid, the brain floats in CSF. When we drain the CSF out, the brain can sag. And when that sag happens, all of our careful planning on historical images kind of goes out the window because now things are in different locations than what we thought they would be. Luckily, that sag does not affect the deep structures very much. It affects the surface much more than the deep structures. But that's another reason why we really like to rely on our neurophysiology in order to make sure that we're at the right target. But that movement, in practical terms, because these electrodes are so big, if they move a tiny little bit, it's not going to affect the way that current spreads to the surrounding tissues.
Do you have to worry about the volume of neural tissue that you've displaced in order to get the electrode down to the brain?
It's an extremely small volume, actually. Neurosurgeons routinely do things like take out an entire frontal lobe. So, for us, this is a microscopic procedure. That area of brain tissue that we sacrifice in order to introduce the electrode. We do it in non-eloquent areas of the brain. We're not going to pass this thing through primary motor cortex, because then we might expect potentially some sort of deficit, although possibly not. The human brain is very resilient, so we're not very worried about displacing that amount of neural tissue. In fact, it can sometimes help. People used to lesion these structures in order to reduce symptoms, and sometimes that can be helpful. Are we at time, Krishna, or do we have time for?
One more minute.
Okay.
Last one or two questions.
Okay. Yeah.
So, thinking beyond DBS, I know that there is some interest in the use of ultrasound as a non-invasive means of stimulation, or for example, the heating of tissue that could be used to burn tumor cells inside of the brain tissue and whatnot. And I guess when you think about something like that, and you think about having all these different transmitters on the brain that are like doing beamforming in order to target a specific location. I know you talked about just the difficulty of placing an electrode to get like the specificity of DBS, but when you think about like something like that and getting that same amount of specificity, how do you think about that? Or
it's actually, we're doing that. We're actually doing that. So we're using focused ultrasound to treat tremor. We shave the head, attach something to the head that allows us to put water, and then 1,000 ultrasound transducers that are focused on one area. And you can do it under real time. You can use a technique called MR thermography, where you can look at the heating of an area in real time. So we can actually do real time, extremely precise lesioning for things like tremor. So that trial's ongoing here at Stanford.
Maybe one more last question. We got to get Jamie back over to the OR.
Do you normally wait till patients are older and the disease has progressed to do the surgery because of the limited time scale it works for?
Yeah, it's no. You don't want to wait too long. It seems that there's probably an optimal time to do this, and it's people are looking at earlier and earlier times. And in fact, there's one study that's ongoing now at Vanderbilt University, looking at early intervention after even just a couple of years of diagnosis. So we think earlier is probably better.
So let's thank Jamie again for an extremely interesting and exciting.
Thanks, guys.
Thanks so much for sharing your time.
No, my pleasure. Absolutely.